Welcome back. At this time, we'll have our public comment period. Is there anyone here with us today who would like to give us a 3-minute public comment? At present, we had one person who signed up for a public comment, Mr. Brian Scarpelli, who's the Executive Director of Connected Health Initiative. We'll await to see if Brian is on. Not hearing from Brian and hearing none in this public space, this is the end of the public comment period. Now the committee will discuss everything we learned yesterday and today. Based on this public meeting, PTAC will submit a report to the Secretary of HHS with our comments and recommendations on using data and health information technology to transparently empower consumers and support providers. Committee members, please refer to the potential topics for deliberation document on the table in front of you during this discussion. If you have a comment, please flip your name tent up, or for our virtual committee members, please raise your hand in Zoom. Who would like to start? You want to read? Lee?
Thank you, Chinni. So Larry Kosinski sent in some written comments since he was unable to attend this portion of the meeting. So his thoughts are as follows. One, he says he was very impressed with Mendel Erlandson's presentation, loved his concept of care coordination management as being the middle earth, the important middle part in the process. Build the brain to amplify the heart is a powerful statement around making AI more human. In our world of value-based care, it would be great for AI to build the neural pathways, to build anticipatory care management and make it more automated and less labor-intensive. There is still an issue with communication from care coordinators, care managers to providers. We certainly know that to be true. There is an opportunity to leverage ambient recording to generate AI solutions around care management, and he thought that was a powerful opportunity. In the second session, Larry's comments were focus on the business model of the practice in creating value-based care solutions. We've heard this over and over again over the last several years. Risk coding is a problem. The practices are not doing a good enough job coding for risk, and we clearly heard that they are uncertain what the value in it is for them. Proactive care solutions need to be first dollar and not incur a copay. This could be a waiver option for us to suggest around the CCM and TCM codes. Those were Larry's comments.
Any other committee members want to comment on the last 2 days? Go ahead, Jay.
It was very interesting about the AI applications that may be possible in healthcare, especially in physician reimbursement models. And I think it's something that our committee should seriously consider recommending to the secretary, that we really kind of open it up to non-traditional providers per se to bring us AI models. And I think it's worth exploring.
Thank you, Jay. Krishna?
Yeah, it sounds like, Larry mentioned it too. It was nice the copay thing was interesting to just see some of these simple barriers that come in the way of broader value-based care, broader patient empowerment engagement. So I think it's certainly an opportunity for us to spend some time just surfacing up those sort of smaller barriers that we can recommend to be revisited, either in the context of a waiver or just otherwise, like benefit design sort of improvements as well. So I thought that was a good sort of takeaway for us. Two was Jay's point on the AI stuff too. I think that feels like there's worth experimenting in the context of incentivizing and making sure there is experimentation being done in the AI space. So setting aside some incentives to further, whether it's AI care coordination or some way of like creating more capacity for the healthcare system, because I know that's a sort of broader provider shortage is an issue anyways for us. And so a way for us to responsibly test AI by incentivizing, I think might be worth, worth sort of we're making that recommendation too. So.
Lindsay?
Yeah, thanks, Chinni. +3, I guess the issue of removing cost-sharing barriers or co-insurance barriers for care coordination or things. I think we've heard this in multiple meetings. It continues to get shared again in the context of new tools and data and AI. So not a surprise, but again, I agree with Krishna. Maybe there's some low-hanging fruit in terms of more explicit recommendations for waivers for existing programs to just remove that barrier. I think two things that were unanswered but raised in the conversation here is just the amount of potential new data and tools that are about to be introduced into the space and wanting to be paid for, and a real lack of metrics and success measures. So identifying a gap as we think about potential payment, we're going to need to think about how we measure success without just introducing more process measures to further glut the reporting and burden of documentation. I think we also heard a little bit yesterday around just as we need to be thoughtful that payment can keep up with the volume of things that are about to hit primary care doctors in particular, but physicians of all specialties, and really need to be thinking as while, moving to total cost of care, payment models might be the goal. If we don't come up with interim things, we're going to drown our primary care workforce in the amount of data and things to come. So I think really getting more people on the team involved in care coordination with all this increased data, AI maybe is one part of that team. And I think the final piece would be as we ask for patients and providers to be more comfortable with engaging in alternative data sources, I think we have to be thinking about what are the guardrails to ensure that data isn't used to deny payment. So I think with the potential, I don't know that we have heard really the sufficient guardrails to ensure that people who are surfacing and looking at this amount of data don't also have that used against them to say something wasn't done or a metric was not made.
Walter?
I was quite struck by how different the content of day 2 today was compared to day 1. I felt like day 1 was much more about empowering consumers, and today we spoke about data and health information technology more to support providers, and so I felt that was a good mix. I see a lot of potential in using data better to support providers. The whole AI panel discussion was fascinating, and I think shows how rapidly that technology is changing the very practice of medicine. And it also, I was impressed with organizations like Harbor Health, who is using data to help patients make the right choices, especially with kind of steering them to higher quality, more efficient providers through the use of lower or no copays, as an example. So there's a lot of promise there in terms of using data and health information technology to support providers. In terms of empowering consumers, I came in, as I said yesterday, as a skeptic, and I leave as a skeptic. I think empowering patients, activating them without making them accountable in some way, shape, or form in their own healthcare might be good, but not sufficient to make this a worthwhile effort in total cost of care models. And a large part of that is because we don't have much evidence that empowering patients, especially in the Medicare population, especially in the seriously ill, that drive a large part of Medicare spending, that this really affects outcomes. And so I think there's a lot of room to develop more studies, create the evidence base that supports patient empowerment and engagement really matters to improving outcomes, both quality and cost outcomes. And I think there's a lot of opportunity for CMMI to maybe embed some of these ideas, these technologies into payment models to test them and see if they actually work to achieve the desired outcomes.
Thank you. Josh, did you want to weigh in?
Yeah, really appreciate the last 2 days. Has my gears turning on a number of things. I think integrating a little bit of what I mentioned yesterday with some things we heard today. I mean, I think some high level takeaways. I think first, I think innovation is welcome and good, but really should be purpose driven. I think data and technology and what we can do really should ideally serve the public good and that interest. And while I think there are many stakeholders, value for taxpayers, beneficiaries, really, and public programs should, I think, take precedence over enriching private interests. And I think that should be front and center. The second is, I think trade-offs, as I mentioned before, I think are real and have to be navigated and not ignored. And so, personalization has to be balanced with systemness, speed, balanced with safety, novelty, and equity. And I think, we should just be explicit in our choices around that. I really like to start the last 2 days about thinking about real scalable solutions. I heard a lot of we should. I think it's a great place to begin. I'd love, as other committee members have noted, to kind of get to kind of what are we doing now? What are we learning? So I look forward to more of that in the future. I would just caution us to be a little bit hype aware and evidence-based. I think lots of, I, among anybody, am excited about the potential of prediction, ML, AI, et cetera. But I think it's fair to say at the aggregate level, many use case benefits are stated, perhaps overstated. Monitoring is relatively limited, and the unintended consequences of any technology are real. I think we need to remember that. Final couple things quickly. I think just addressing the economics of change. The silos that some of our SMEs talked about are not just technical; they reflect business models and structures. And so I think breaking them down has consequences. Some are obvious, some are less so, and I think we need to acknowledge and manage those. And then, I was reflecting on the charge of us as a committee, thinking about physician-focused payment models. And I think, one of the things that I'm reflecting on is not everything in every program needs direct payment. And this reflects other people's comments about how are we going to pay for all this and how would we do it. Reflects comments about how maybe there's not any perfect way of exchanging money across hands. But, if you think about Medicare as an example, most of the things covered under Medicare are covered under bundled services, whether that's the inpatient prospective payment system, the outpatient system, et cetera. We don't parcel out every single thing into a code or a discrete service or coverage determination. And I think that's probably for the better. So as I reflect on some of the comments from today, it makes me wonder kind of, where are the places we should kind of artfully not do anything related to payment for some of these things. If the business cases and the economics are as real as some of our SMEs are suggesting, there shouldn't be necessarily that motivation to do that. So I would just be cautious, because otherwise I think we could run into this risk of kind of doing more to do more. And part of us finding balance is to do less strategically and to do more in other places. So thanks.
Thank you, Josh. Lee, did you have any comments?
Appreciate all of those comments and agree. I was struck at times today that regarding AI and advanced data systems, we were hearing essentially the plea that it made me go back to my systems theory training about the whole point is to make it easier to do the right thing and harder to do the wrong thing, and make it so there's enough safety built in the system that you almost can't do the wrong thing, right, without breaking glass. And so I'm going to be the third person to mention it, but I was struck by, we've been talking ever since the codes were created about the barrier to patients and doctors to do the right thing of the copays in the CCM, the TCM, and the collaborative psychiatric care management codes. So again, I think that's a perfect opportunity for CMS in its waiver power or model design to remove those barriers to getting higher value care. Heard a strain today that hasn't been picked up quite yet about focusing in on some of the supplemental benefits in Medicaid and MA and emphasizing the benefits that are proven increase value and health outcomes and systematically reduce those or take off the table those that are mainly about marketing. I mean, I know in MA it's a private company's money to spend as they choose, but it's still within program design parameters. And for Medicaid, where you're very directly spending taxpayer money, even though it's a supplemental value add benefit, it should be for something that actually adds value, not just adds marketing or splash. So certainly we heard food benefits, transportation benefits, hearing aid benefits are key and actually are almost never included in Medicaid programs. So I would focus in on those for sure. And then on AI, really jazzed and encouraged by the conversation, love to hear about stories of innovation. I was struck multiple times that the AI innovation world is racing ahead far, far faster than our regulatory compliance and legal framework can keep up with. And that perhaps the most conservative force known to man is the compliance attorney team in any modern health system. And so I think that's a good opportunity for, again, through its regulatory powers and or waivers and or model design for CMS to offer some, perhaps through MSSP, but just to offer some safe harbors for use of the AI tools that are clearly driving value and lowering costs. And take it a step further to say if it's clearly increasing value and quality of care, why do we not rush to essentially make that the expectation, as opposed to that's the innovators. Let's try to tip from the early adoption innovators as quickly as we can to mainstream adoption, and that there might be a role for a model to overtly incentivize the use of these, and then that would allow some A to B testing from those who have adopted it, those who have not, and prove its value even better. So that's what I had.
Thank you. And I have just a couple of things to add to the entire committee's input. I think the power of AI is to be seen in healthcare. I mean, healthcare is one of those places where I think it holds the most promise, particularly because it has computational power to tie in data sets. And I think one of the things that came in the conversations was the ability for personalization, whether it was yesterday or today through the care management platforms. That level of personalization that allows us to deliver sort of that human loop care is where I believe there's the greatest promise. The other thing that hasn't been mentioned that I was struck by was the identity management that came in, and how the ability to actually have appropriate identity management allows for patient consent and allows for it to be seamless through multiple environments. And that's something that can be done today. So we don't have to wait for that. We don't have to worry about, we do have to worry about compliance, but we don't have to, there isn't a proof point. We know that works because it's been done in so many other situations. So I think that's one thing that we should stress. I want to double click on what Lindsay said about the inadvertent use of this computational power and the ability to tie various data sets together. While they're powerful in personalization, we do have to make sure that there are guardrails built into the system to not inadvertently create more disparity in benefits or create more disparity in outcomes, as well as be used as a power to deny payment for things that that meritoriously deserve payment. I think my favorite line was, that incentives for the use of ethical and meaningful use in AI is maybe a potential that can increase adoption in a rational way. So with that, Josh, I believe you have another comment.
Yeah, sorry, if we have time if the co-chairs will permit time for committee discussion. Okay. I think, I was reflecting on actually just these last few comments. And I think, again, it's important. I think Lee yesterday made a really important comment about, stagnant reimbursement for physicians and, how payment to physicians and group practices obviously can drive innovation. And yet this comment about the copay for something like CCM or other things highlights the point that increasing payment increases the burden to patients as well. And so we're not getting away from, and by in turn, taxpayers and beneficiaries. So we're not getting away from that in any of these kind of conversations. The other thing I really take, Chinni, your point really well. And I'm struck with kind of this idea that one of the driving motivations for groups like ours and others is that we believe there's waste and redundancy in the system. And so you would imagine in an ideal world, like the data would help us identify those, right? That we should stop paying for certain things, but then we also want to start paying for other things. And so I think I would just, encourage us as a committee to kind of think about that, reflect on, what our partners at CMMI and other places are doing when they're judged to things like cost savings and stable quality or stable cost and increased quality. We urgently need data around these things. But as you try to solve the one problem, I think we could potentially create, issues with the other. And I think this copay discussion is a great example. And I think data to, determine coverage determinations is another. I don't know those are purely good or bad things. They're both.
Thank you, Josh. Anybody else have any additional comments? So barring none, I'd like to thank all of our committee members for sharing your very valuable comments across this two-day meeting and your time in spending the day here, the 2 days here. Before closing, I'd also like to check with the ASPE staff to see if there are any clarifying questions for us. Marcia, Steve, do you have any questions or comments?
I don't. Thank you so much. It was a very good conference. Thank you.
Yes, I think it was a great meeting, and I think as support staff, we have the responsibility now to take all of this information and fit it in the framework that Krishna presented yesterday morning in order to make a good report to the Secretary.
Thank you. And prior to closing, I'd like to mention a committee member who was unable to be here today, but this is his last formal meeting, Jim Walton, who's served on PTAC with us. We will miss him, and we wish him well in his endeavors. And Jim's been an incredibly valuable voice on this committee, speaking for many parts of the healthcare system that are often overlooked or marginalized. So thank you to Jim. I want to thank everyone for participating today, our session experts, my PTAC colleagues, and those listening in. We explored many different topics using data and health information technology to transparently empower consumers and support providers. Special thanks to my colleagues on PTAC. There was a lot of information packed into these 2 days, and I appreciate your active participation and thoughtful comments. The committee will work to issue a report to the Secretary with our recommendations from this public meeting. And with that, one final thank you to the committee and session experts for joining us to make this a memorable and informative PTAC public meeting. This meeting is adjourned.
Produced by the U.S. Department of Health and Human Services.